As we know, retinoblastoma has been a very spectacular success story in the West. From 95% mortality that we used to have 50 years ago, now we have 95% survival, a total reversal. But in developing countries, it still carries very poor prognosis, not just because of poor diagnosis, but also because of delayed treatment. Would it be possible to have cost-effective protocols that are applicable to developing countries and mirror the prognosis that are seen in the West? That is a question we need to answer. The diagnosis is very simple for a retina surgeon. It's not difficult at all. All you need is a good clinical acumen and a good examination under anesthesia. You really don't need high technology tools to diagnose retinoblastoma, but of course there are screening tools such as MRI scan and CT scan which will help you diagnose a trilateral retinoblastoma where indicated or extraocular retinoblastoma where you suspect. Clinical spectrum we are all aware of. Starts as a small tumor intraocular, grows on to occupy about 2/3 of the ocular volume when you see leukocoria, and then the child may have squint at that stage as well, depending on the location of the tumor. Orbital manifestation, as you see here, are currently rare. But what are important are to recognize the masquerades. As was being shown earlier, hypopyon is a feature in older children, diffuse infiltrative retinoblastoma. A child can even come with thiacal eye with retinoblastoma in the other eye. So don't attribute thiasis to a vague history of trauma, but make sure that you examine the other eye completely and properly. There can even be cataract, orbital cellulitis, hyphema, and vitreous hemorrhage. Just to show you an example, this child came to a pediatric retina specialist with vitreous hemorrhage. But what is curious here is that the blood vessels are dilated. Vitrectomy was performed, the child developed rhegmatogenous retinal detachment, even that was repaired. But even on the buccal indent, you can see that there are creamy white areas now which are progressing posteriorly as we see. We all believe that retinoblastoma occurs posteriorly and progresses anteriorly. But in diffuse infiltrative retinoblastoma, as we know, retinoblastoma develops at the ora serrata after, say, 1.5 to 2 years of age. It progresses both anteriorly as well as posteriorly. And when that happens, it is acalcific. In a 5-year-old child, retinoblastoma is typically acalcific and presents as a diffuse infiltrative lesion. You can see that there is hardly any tumor here, and even on enucleation, you don't find a big mass. All you find is diffuse thickening of the retina, which is just twice the size of the normal retina. So these are the kind of vague manifestations that we must be aware of. And if a child presents with vitreous hemorrhage or hyphema, you must investigate thoroughly before jumping onto any sort of intraocular surgery. So concept number 1 is retinoblastoma can be diagnosed very easily using basic diagnostic tools. Understanding of atypical manifestations and avoiding intraocular surgery in such situations actually helps prevent disseminate the tumor extraocularly. Classification, any classification should be very simple and easy to recall. You cannot have classifications that are difficult and that you can only recall by looking at the textbook. Classification should also follow the current treatment modalities. And when you look at retinoblastoma, we have moved on from radiation to chemotherapy. And Rees-Elswer classification is little complicated and always prognosticated radiation as the primary treatment. Now with the new treatment protocol, we have a new classification system, which is a kindergarten classification, A to E. Group A is a tumor less than 3 mm. Group B is tumor at the macula more than 3 mm or with subretinal fluid. As the tumor enlarges, if it is exophytic, it will have subretinal seeds like this with SRF, that is group C. C is for confined subretinal seeds or confined or focal vitreous seeds. Vitreous seeds develop in endophytic retinoblastoma. As the disease progresses, these seeds become diffuse. So D is for diffuse subretinal seeds or diffuse vitreous seeds, and E are potentially enucleable with neovascularization of the iris, glaucoma, hyphema, and vitreous hemorrhage. So it's very simple classification, and that can be directly translated to prognosis in case of retinoblastoma. As you see, the prognosis is very flowing with international classification, whereas the same group of patients have very haphazard prognosis with Rees-Elswer classification. So the new classification system is something that we must adapt to. Also, there is international staging, but done by Shantada, and TNM staging, which are for extraocular retinoblastoma mainly. So concept 2 is simple and clinically relevant classification system has prognostic implication. Coming to management, like in any cancer, the first or the primary goal is to save life, if that is possible, you go on to salvage the organ, and if that is possible, you go on to salvage vision. In small tumors, life is never a question. Eye is never a question. You can save the eye, you can save life. In such situation, you concentrate on maximizing visual potential. Cryotherapy is an excellent tool, has 95% success. 1, 2, 3 sessions of cryotherapy can cure tumor in about 95% of situation. The tumor generally is about 3 to 4 millimeter in diameter, located in the periphery, 3 to 4 millimeter in thickness, but the size of the scar that is produced consequently is much larger than the tumor that you began with. So if the tumor were to be located on the temporal aspect closer to the equator, cryo is not a good idea. But nasal periphery, cryo may be a good idea. Cryo can also cause rhegmatogenous retinal detachment. So you must be aware of these implications before resorting to cryotherapy. Laser photocoagulation is totally out. Laser photocoagulation, the principle is to anemize the tumor or cut off its blood supply by applying 2 rows of large diameter laser burns around the tumor. So if you begin with a tumor which is about 3 millimeter, you end up with a 6 or 9 millimeter scar because you would have burned the retina around the tumor, not just the tumor. And you can see what is happening to the blood vessels. They get blocked because of laser, high laser. So you end up with a scar that is much larger than the tumor, and suppose the tumor were to be located in the juxtapapillary position. What will happen to the visual field? The child will have a dense arcade scotoma, which is totally unacceptable. So in small tumors now we have shifted on to transpupillary thermotherapy, delivered with a large diameter indirect laser delivery system, which is 1300 micron. So a tumor which is about 3 or 4 millimeter can be treated easily in 2 to 3 minutes, as simple as that, and it is directly treatable over the tumor, not around it, because the principle of TTT is totally different. It increases the intratumoral temperature by about 45 to 65 degrees centigrade, thus inducing very gentle apoptosis of the tumor, resulting in a very nice gentle scar. So the scar is never larger than the tumor that you began with, and the blood vessels that pass through the tumor are classically spared with transpupillary thermotherapy, thus maximizing the chance of visual potential. So when you have a chance to save the life and eye, you have to resort to treatment modalities that maximize visual potential. Plaque brachytherapy is also a similar technique, useful for tumors which are about 16 millimeter in diameter and 8 millimeter in thickness. The ruthenium isotope that we use is excellent because it has a very nice fall-off radiation. Even in a juxtapapillary tumor that you see here, this is a dosimetry. The optic nerve is getting only about 500 centigrade, which is very, very acceptable to the optic nerve health. So a nasally located tumor can be easily treated without causing optic atrophy by using a notch plaque. Plaque brachytherapy is a very simple surgical procedure. All you need to do here is to localize the tumor nicely. Localization is the key. Dissection is simple. You have to isolate the extraocular muscles that is around the tumor. By your clinical localization, you mark where exactly you want to place the plaque. That is the episcleral mark. Confirm that using a dummy plaque, that's a silicone dummy plaque that is being used before we actually place the hot plaque. And on top of that, you can actually use a transscleral laser such as a diode laser and confirm the location. That is what is being done now. And then the hot plaque is placed. We want minimal exposure of the medical personnel to hot plaque, so every bit of localization is done with a dummy plaque, and then the hot plaque is placed and sutured into position. That is the end of surgery. So at the end of exposure period, you simply have to go back and remove the plaque, and this is the kind of results you can expect. Tumor regresses drastically, but you can if you note very clearly that RPE changes extend to exactly where the tumor was earlier, although the tumor has been reduced into a flat scar or a stable scar. So visual consequences are there with plaque brachytherapy, and you should be aware of it. The scar that is produced is never smaller than the tumor that you began with. That is one of the disadvantages of plaque brachytherapy. So in focal therapy, the concept is less is more, and you have to resort to modalities that maximize visual potential. In larger tumors, we have local or systemic therapy. EBRT is extremely bad, not because of other complications, but because of second malignant neoplasm. The risk of second malignant neoplasm increases to 35% versus 6% in patients with bilateral heritable retinoblastoma that have been treated with EBRT, which means that we will kill about 29% of these patients when they become older, teenagers or in their 30s, by doing radiation or exposing to the risk of radiation when they were younger, so it is not acceptable. Concept 4, EBRT is never currently used as primary therapy and is the last choice as secondary therapy. What we have to replace EBRT is chemoreduction. Chemoreduction is like going back in time. If you begin with a 16 millimeter tumor, you can go back in time, reduce it to 4 or 5 millimeter size tumor, and then hit it with focal therapy. That is possible with a combination of carboplatin, etoposide, and vincristine. You can see the results of chemoreduction. We began with a tumor of this size and a tumor here, reduced to a flat scar, macula exposed, fovea exposed, good visual potential. We would never be able to achieve a scar smaller than the tumor with any other modality except chemoreduction. Similar example here, tumor abutting on the foveola, regressed away from the fovea. Tumor always regresses towards its blood supply. Blood supply is from the supratemporal arcade, so tumor would naturally regress towards it. It will hold on to its blood supply till the very end, thus freeing up fovea and potential for good visual recovery. Similar are many examples here. You can see a large tumor with focal vitreous seeds reduced to a flat scar at the end of 6 cycles. Similar example, child presenting with total retinal detachment reduced to a flat scar. One more example, another example here. This large tumor reduced to this flat scar, and the patient even had retinal detachment at one point in time, totally regressed with treatment. Good visual potential. Chemoreduction is magical, but the problem with chemoreduction is that it is not able to treat standard chemoreduction. It's not able to treat advanced retinoblastoma, which is our major problem. 75% of patients in India manifest with results worth 5. So standard chemoreduction that is practiced in the West has limited success in group D and group E eyes, as you see here, and so we need a change in protocol. And the options that we have here are high-dose chemoreduction and periocular chemotherapy as a combination, intra-arterial chemotherapy, intraocular chemotherapy, and radiation. We don't want to use radiation, so we are left with other choices. Intra-arterial chemotherapy is an excellent technique, emerging technique, has to be validated, is very expensive. In Indian circumstances, you can treat 30 children with high-dose chemotherapy with the cost that you incur with intra-arterial chemotherapy. So I use it very sparingly. We have the facilities available, but I don't want to impose it on patients where it is not really indicated. It is currently used as a salvage measure when everything else fails or we have no other choice left. So what we are left are high-dose chemotherapy, periocular carboplatin, and intraocular chemotherapy. High-dose chemotherapy uses the same drugs but in a higher dose and has about 76% chance of eye salvage in results worth group 5 retinoblastoma. You can see that with high-dose chemotherapy, diffuse vitreous seeds that you see here are all calcified and the tumor is completely flat. One more similar example where all the diffuse seeds are calcified and the tumor is completely flat. One more example. This was the only eye of this child, other eye having been enucleated. You can see nice results here. Tumor is stable at the end of 3 years. Macula is healthy. The disc is partially exposed and healthy. This child enjoys 20/40 vision from being enucleated. Now, intravitreal melphalan and topotecan used by a safety enhanced technique where there is no scope at all for extraocular dissemination of the tumor has excellent success in focal vitreous seeds, as you see here. One more example. In fact, topotecan is so gentle on the retina that simply erases these cells in 2 or 3 injections. But you have to make sure that you give it by a safety enhanced technique and not cause extraocular dissemination of the tumor. One more example of the same. So with this combination, we have about 76 to 80% success in advanced retinoblastoma. Now, enucleation has been standardized. We all use implants and give them good cosmesis. It's difficult to differentiate which eye has been enucleated in the second picture that you see. But the problem with enucleation is that you have to resort to a long optic nerve stump. In this patient who actually has optic nerve extension, if you were to go by the textbook and cut the optic nerve at 10 millimeter, you would still be left with residual tumor at the cut end, which means that the child would have 75% mortality. Just by extending the indication, going a few millimeters beyond and cutting the optic nerve at about 18 or 20 millimeter, you have had a free optic nerve stump, thus reducing mortality to less than 5%. So aim at more than 15 millimeter, as long as possible, up to 20 millimeter if you can, by a modified enucleation technique. And beyond enucleation, we have to identify high-risk factors, because 55% of Indian eyes after enucleation are found to have high-risk factors which directly translate to systemic metastasis. In such patients, adjuvant chemotherapy is mandatory. As you see here, 24% is the risk of metastasis in patients with high-risk factors, whereas if you give adjuvant therapy, the risk reduces to 4%. So we have an additional survival benefit directly translated to 20% children. So small measures like this actually add up to give you better life salvage at the end of your protocol management. Now, enucleation is not the end of clinical management of retinoblastoma. It's just the beginning, is the concept I want to drive home. In orbital retinoblastoma, we have multimodal protocol that we begin with high-dose chemotherapy. With high-dose chemotherapy, the orbital component completely reduces and the eye goes phthisis. As you see here, this orbital component is gone. Eye has gone into a complete phthisis, at which stage you would safely enucleate, get a long optic nerve stump, and then follow it up with external beam radiation and adjuvant chemotherapy. You can see this patient has cavernous sinus extension, which was never conceived survivable until 5 years ago. Now these children do survive by multimodal treatment protocol. You can see excellent result. The tumor, all that is left is here, which can be easily tackled with stereotactic chemotherapy. Fortunately, these children have unilateral retinoblastoma without germline mutation, and they don't develop second malignant neoplasm. Optic nerve extension until the apex can now again be tackled with multimodal treatment protocol. And these children live on to have excellent cosmesis as well, as you see here, without having to undergo destructive orbital exentration. So concept 9 is orbital retinoblastoma can be managed with multimodal therapy. I don't have time to go into the genetics, but I would just like to say that molecular biology techniques and genetics can predict retinoblastoma and avoid in families, because you have preconception screening, in vitro fertilization techniques that are available to stop retinoblastoma on its track. So with all this, the overall outcome can actually mirror the West. These are very inexpensive treatment strategies that I outlined, costing less than 5,000 rupees per month for 6 cycles, which is less than the cost of a cataract surgery these days. With all this, we have 95% survival and only 5% go on to develop metastasis, even in advanced situations. And those who have chemo reduction, 90% have eye salvage, and those where vision could be measured, 50% had vision equal to or more than 20/40. So I'd like to summarize that, yes, cost-effective protocol-based management by a multidisciplinary retinoblastoma team can help mirror eye and life salvage rates achieved in the developed countries. Thank you so much.